Hello and welcome to Insight, everyone. I'm Nnamdi Odikpo.
And I'm Elizabeth Omori. Thank you for joining us on Insight this week.
February 4 every year is commemorated as the World Cancer Day, and it is used to generate increased awareness on cancer and also used as an opportunity to push for more action. It is against that backdrop that our first conversation on the program on this episode would center on cancer care and treatment in Nigeria. And then my next conversation will highlight the plight of migrants, especially Nigerian migrants, facing difficult times arising, due to their irregular status in some of these countries, or host countries. More Nigerians are being deported from Europe, and now we hear about the numbers in the United States who are facing deportation, as it were. What are the expectations in terms of how deportees are supposed to be managed? We'll talk about all of that. And of course, Elizabeth is here. Lizzie?
Well, another issue of concern is self-medication, which is the practice of treating oneself without the guidance of a medical practitioner. Changing this narrative is also on our plate on this segment.
Very well then. Let's kickstart the program.
Whatever the issues are,
the National Assembly is constitutionally empowered to scrutinize,
however complex or intricate.
We have involved all the academia, the members of the academia. We have involved the academies.
Be it government policies or in fact any issue of public concern.
Our job is to help you gain clarity and make sense of it all.
This is not really healthy for our democracy.
There's a lot of agreements in terms of who has been in power longest and who becomes the governor of the state.
It's also in the quality of food being consumed.
After all, perception is insight.
And gaining understanding is also getting insight.
Cancer remains at the top of the list of diseases negatively impacting the welfare and wellness of persons across the world, particularly in developing countries like Nigeria. And you know what? Why successes in treatment is improving in the developed world with near 100% cure rates, recorded in certain instances. The situation could be better here in Nigeria, where the mortality rate is said to be on the rise. But let's find out if that is really the case and why that is the case. My guest is the Director General, Institute for Cancer Research and Treatment, NICRAT, Professor Usman Aliyu. Prof, thank you so much for coming on Insight.
Thank you for having me.
Prof, I did attempt to get some of the data on new cancer cases in Nigeria, but I think data in that regards is limited, even though there are estimates, I must say. But one data says 128,000 per year, and that's the rate of new cancer cases in Nigeria. But when it comes to the death rates, that's a different matter. And whatever figure you look at, it all shades of no and alarmingly frightening. In fact, Prof, I read somewhere that the figures are even underreported. But depending on the data that you have at the center, at the institute, which cancer cases or which cancer are more prevalent in Nigeria, which gender is more susceptible or mostly impacted, and why?
All right, so thank you very much for the question. If we are talking of data in cancer, globally, we rely on our cancer registries.
Okay.
Wherever, regardless of the country. And it is from these cancer registries that an agency of a World Health Organization that is charged with the responsibility of reporting cancer statistics, in this case, incidence, morbidity, and mortality, called Globacam, annually or periodically report these statistical parameters that are of great importance in policy making and in making decision. The most recent one, the report by the Globacam was in the year 2022.
Okay.
Yeah, and from that globally, there were about more than 20 million new cancer cases. And a death toll of there about 10,000 plus were recorded also in that year. In Nigeria,
would that be over a given period of time, or was that was that
yes, the report in that year,
okay,
early 2020. So, and in Nigeria, the report that we got in the year 2022 from our 3 main population-based cancer registry. Now it was reported that there are about 128 that you've mentioned new cases were recorded, and there are about 74 to 75,000 new deaths related to cancer were reported in that year. However, these are just like a tip of the iceberg, most especially if you look at the African subpopulation, where subcontinents, where we are lacking in these data centers. There are countries in Africa that virtually has only one population-based cancer registry. There are some that doesn't even have a single population cancer registries, but rather what they have a hospital-based cancer registry. We here in Nigeria, we have 20. There are about 20 hospital-based cancer registries and 13 population-based cancer registries. Currently under our watch, that is under our care, the National Institute for Cancer Research and Treatment. The institute is working insidiously to see that we have upgraded the registries, because it's very important. It's been long that the registries were not under any governmental agency, not even under the Federal Ministry of Health, but under they were run under a kind of a grant. So, but with the coming of NICRAT, the Federal Ministry of Health now working with some other well-meaning Nigerians, now handed over the responsibilities of this cancer registry to NICRAT. I'm now happy to say that our population base are currently under upgrade.
Okay.
Upgrade when we talk about buying new equipment like the hardwares like the computers, the software like the CanReg 5, which is the interface that is currently being used worldwide, and we are still also embarking on training and retraining of cancer registry staff. The importance of this is to have a reliable data, and now it is only when you have reliable data that you can adequately plan for care now in the country. We are also pushing hard to centralize, to have a central pool for virtually all the data that we have, so that at any time the government can make reference to National Cancer Institute Central and database, and to get data that we can adequately plan and make policies out of those. We have to be very grateful to this government for giving us that budget line to work on. We started in 2024 and we hope to continue. So that maybe by in the next 1 year, we hope to have a reliable data that we can always bank on when it comes to cancer morbidity and mortality.
Prof, and like you rightly said, data is key and germane to all we do, whether in terms of our response, whether in terms of allocation of revenue and all of that. I did ask at the beginning I did also ask what the data are saying with regards to prevalence of cases in Nigeria and which gender is most susceptible as well, and why.
Okay, so from the data that we have, the commonest cancer is breast cancer.
Okay.
And we know breast, when we talk of breast cancer, we are talking about women, the female generally. But it's also very important to know that even male do have breast cancers, but it's commoner, much commoner, in the ratio of they are about 98 in the female, and they are about 1 to 2, depending on where the statistics or the research was conducted coming from. So it's much commoner in females, and it is the #1 cancer, not only in Nigeria but globally. That is breast cancer. Now, women are known to have more cancers globally than men. This is actually the same with Nigeria, because if you come to Nigeria, the 5 common cancers that we have, the first one is breast cancer. Then the second, cervical cancer. Then we have prostate in men. Then we have colorectal cancers, and then liver.
Would it be correct to say that we are, as it were, currently strengthening institutional response, that we are increasing resource allocation and building our oncology workforce and services to tackle, our national cancer burden, as it were, right now? And in terms of research, Prof, and this is an area that I know you're deeply and keenly invested in, how effectively has the Institute, or rather, how effectively have we been contributing to the pool of knowledge on the diverse cancers that we have, or perhaps maybe let's limit it to the prevalent ones here in Nigeria? How impactful has our contribution to this pool of knowledge been so far?
All right. So thank you very much once again for the question. Since the establishment of the Institute, we have to commend the government of Bola Tinubu for giving virtually a very good budget to the Institute, although there is always room for improvement. But the Institute in the year 2024 embarked on regional cancer campaign awareness. And this awareness is just to educate the community on the possible risk factors of this dreadful disease. Trainings were also conducted to front-line healthcare personnel in the primary and secondary hospitals across the 6 geopolitical zones. And the training were to improve their knowledge in the signs, symptoms, and also the common risk factors in cancer, so that if anybody comes to the hospital with such signs and symptoms pointing toward cancer, they can do the needful by doing the required investigations and then refer the patient promptly. The importance of doing this is it cannot be overestimated, because the treatment of cancer, we all know, is capital intensive, and at an advanced stage the chances for cure is very bleak. But if you catch them early, you have a window, you have the chance to cure them when the right thing is done. So it was out of that we escalate a regional-wide cancer awareness campaign and also screening program. It will amaze you to know that the Institute also is currently working to establish screening centers in 6 of our tertiary hospitals in the country. The importance of this is that people in that region can at any time, if they so wish, walk into the hospitals and get their self screened for these 5 common cancers that we have discussed about. And they can ask the oncologist or the doctor that is going to be there on their risks and their chances and so many other questions they want to know. This is how we have to commend the government, because this is happening. It's an innovation of this government. It is happening for the first time in the country. opening a screening centers in the hospital. We are currently upgrading in some centers. We are even constructing. We've already procured the equipment like mammo, ultrasound, colposcopy machine, and we're going to work with these various hospitals to have a dedicated doctor that man or specialist that man those screening services. All this, the importance of this is that we hope to have more Nigerians turning for that screening, and we hope to have more Nigerians presenting early. And once they present early, then we can say that we can do all that is needable to cure them from that disease.
Prof, you sparked my interest when you referenced how capital intensive cancer treatment is in Nigeria. I cannot recall the number of times that I have seen, that I have read, or maybe I heard stories, of people seeking medical support for, one form of cancer treatment or, or care in Nigeria. These days, we see cancer patients and maybe even their relatives, turning to social media to raise funds for their treatment. I know the government, whether at the national level or, a few states as well, are focused on, keying into the national cancer plan and increasing cancer treatment facilities, in their states or nationwide. But, Prof, and I've heard and listened to some of what you said in terms of how, the Institute is working with, collaborating with key partners to expand and build this eco space. But even in doing that, isn't it true that investments in some of the things you mentioned, equipment, structures, maybe facilities, these investments, isn't it true that they must come along investment in affordable access, for there to be significant impact? People need to be able to afford this treatment for us to see, yes, truly we're making inroads and making headway here.
Okay. So I think you are very correct in that. And that is another area that we'll have to commend this government. The government of His Excellency Bola Tinubu under the under the stewardship of Prof. Muhammad Ali Pate, the Honorable Minister for Health and Social Welfare, have hit this, and they are currently working to procure 6 brand new cancer treatment machines as an addition to the 6 tertiary hospitals that we have in this region. This has actually it has reached an advanced stage. And you can see before the advent of this government, I think we have there about, if we can say LINAC, we have there about 4 or 5. And hardly will you find like say 3 or 4 working. So at the first dispensation of this government, 6 brand new equipments were given awarded contract to supply, which we hope to actually see the supply and the completion of the bunkers that will house this machine by by the second quarter of this year. So that alone, you can see, is like there about, let's say, 100% increase in the amount of cancer treatment machine in the country. And once we have that, it's like we are improving access, the availability through providing the needed services. Now, the second thing that you talked about is the affordability of the service. While we know that it's cancer service, cancer treatment is capital intensive globally. it's capital intensive globally. Again, we have to commend this government because there is what we call the National Cancer Health Fund. It is an initiative of the government where indigent patients are supported to actually be able to afford their treatment. And this very important fund is now under the National Institute for Cancer Research and Treatment. Initially, it was piloted to cater for all the 3 cancer cases because of the amount of funds that we have vis-a-vis the breast cancer, prostate, and cervical cancer, and it was piloted in the 6 cancer centers of excellence that we have. That is 1 for each region. But with the coming of NICRAD and the transfer of this very important fund to NICRAD, we are currently working in phases to expand the services to not only the centers, but virtually all the centers, our tertiary hospitals that provide some form of cancer treatment care. We divided the whole country and the hospitals that we have into the feeders, sub-hubs, and hubs. Our primary healthcare centers, as some general hospitals within the rural area, will serve as the feeders, where if some cases of cancers are detected, they can be referred to sub-hubs. And sub-hubs are equipped to perform some form of surgeries, but sometimes some cannot give chemotherapy or there are no radiotherapeutic services. Then from there, once the surgery is done in this general hospital, the patient can be referred to the hubs, and this hubs is where this cancer health fund is actually situated. So through this robust referral system, we will be able to support virtually all the Nigerians that have this cancer patient. We are engaging the National Assembly to improve or increase funding of this cancer health fund. I've engaged several important personalities, and they have assured us that we're going to have more funds in that cancer health fund. So it's actually a very good thing for the cancer patient in the country. We also hope to reach out to philanthropists in the country to support in putting some funds into some funds, because as we have earlier mentioned, cancer treatment anywhere is capital intensive.
Yes. Prof, this cancer health fund that you're talking about, it's already in play. How much so it's impacting? Maybe you'll talk something. In fact, let's just still talk about this whole issue of funding. Because, and if I were to draw up a scenario, because a case scenario, we're having a plan. And that's something we do often when we're planning. We create scenarios and then we test these plans against scenarios. Have we done that with this cancer health fund, just so we measure or evaluate impact? And because this issue of funding, whether we're talking about funding, diagnosis, or we're talking about treatment and all of that, the bulk or the major strata of the population impacted are the indigent ones, like you rightly inferred or referenced earlier. Let's talk about this issue and link it to the National Health Insurance Scheme, which should be able, accessible to all Nigerians, and a key way of reaching out to persons impacted or affected. Except things have changed overnight, I do know for a fact that the NHIS fails to provide cover for many advanced medical procedures, like cancer, making a greater percentage of Nigerians, having to access these services or healthcare services without, by paying out of their pockets, basically or essentially. So cancer is not currently covered by the NHIS, or Prof, is it? You can correct me if I'm wrong. And just what I'd like for you to take that also alongside the fact that smaller countries. Let's take Ghana, Prof, for instance. Ghana. They started NHIS about the same time like we started in 2005, and today their own scheme, covers cancer treatment. When you talked about the cancer health fund, I mistook it for one special program that NHIS does, where they provide 10% payment, for just diagnosis alone. That's not the case here. Why can we not link the cancer health plan to the NHIS plan and see how we can expand the scope?
Okay, so I think it's a very beautiful question, and this I believe has been running into the minds of many Nigerians. But if comparatively, the country, Nigeria, is actually very large, and we have a lot of competing interests, competing issues. Comparing if you want to compare Nigeria with Ghana, with Rwanda, and some other people,
we're often quick
it's
to
quite
compare.
funny.
We're often quick to compare. If
We are
want
always
us to go to the issue of fuel now, and then we'll compare prices. We'll rush to like the price of fuel in this place is this. So why is it that we can't compare in this instance?
Yeah, it's actually because of our population, and you know it's actually quite sad. For years back, the previous regime, that we've been having a lot of issues, the abandonment, and then the poor enrollment, the number that we still have, a number of Nigerians that are enrolled into the NHIS used to be extremely low. We know it's still low, but we have to commend this government because there has been a surge, an increase with the current coming in of the new DG, the new DG. I know there were a program that they have actually launched, and they have presented a very significant and wonderful statistic. They are about, I think, up to, from what they have inherited, they have increased that coverage to almost, they are about up to 25, they are about to 30%. To the Nigerians, it's actually very little, but we know it's, significant, because before the advent of this regime, the coverage was there about, I think, 4 to 5%. But I think it has surpassed that. Don't forget that there are so many elements that we have in the country that the National Health Insurance Scheme is covering. So many elements that you have mentioned. The cancer is actually one of the diseases that they give some certain support.
Unfortunately, I would have to discontinue my interview on cancer treatment with the DG NICRAT, Professor Usman Aliu, as we've spent more than a allotted time for this segment. I'll bring you the concluding part of the conversation in our next episode. Up next is the conversation on migration and the plights of Nigerian deportees. The plights of Nigerian migrants, navigating the treacherous landscape of irregular migration and deportation has definitely reached frightening levels. As the number rises, I beg your pardon, the tale of hardship, harassment, and alleged maltreatment of these migrants have become increasingly disturbing. The irregular status of most of these migrants, whether they are in Europe or the Americas or wherever they are, render them vulnerable to exploitation and abuse, leaving them to face unimaginable challenges in foreign land. Now, deportation, like I did say, is rising steadily, making it imperative to confront the complexities of this issue and explore innovative solutions to address the root causes of irregular migration. There's also the big issue of how to ensure that, the humane treatment and reintegration of deportees. Let me bring in my guest at this point, Reverend Father Emeka Chris Obiezu, OSA. Father, what's the OSA there for?
It's Order of St. Augustine.
Well, he's also the Director of Augustinian Center for Advocacy, Justice and Peace, as well as being the National Coordinator for the Civil Society Network on Migration and Development. Thank you so much, Father, for coming on Insight. It's been a while since you came on my program. You used to be a customer, then you ran.
Yeah, maybe you found some other better persons than us.
Well,
that's
great.
okay.
Fantastic to have you here.
Good to have you again.
There's no one that does it better in this business of migration like you do. So that's why, let's just, double down on this issue. Considering some of the stories, and there are plenty of stories that we've heard, tales from, how some migrants, those being deported back or, already deported back to Nigeria, are treated and manhandled. It raises serious questions on the rights of migrants. As a matter of fact, what are the general and specific expectations under international conventions and laws that protect the rights and dignity of migrants, whether they are Nigerians or not?
Thank you, Nnamdi. It's an opportunity again to be with you and with our audience to share this patent issue on migration as it affects Nigerians and the world at large. We have established it that Migration is a human thing which belongs also to individual human rights as accorded by the Universal Declaration of Human Rights, Article 13, which grants each individual the right to leave their country and to return when they want to. And in different ways, people exercise this right, either to better their condition or to change environment, or for some reasons, just to add to the needs of other countries in terms of development. Many a times also we know that some situations on the ground in terms of root causes of migration push people out of their places to other places. And in some instances, they don't have opportunity to access regular pathways. And some of them avail themselves of the irregular pathways. And as you have likely said, in that condition, many of them are exposed to vulnerabilities and exploitations of all kinds and manner, as it were. But before delving into irregular migration, as the news is making the rounds now, I think it is right to establish that over 80% of Nigeria, I'm sure 90% of Nigerian migration is in regular status.
Okay.
In other words, Nigerians migrate regularly. We are not lawbreakers. We do the right thing. And the latest statistics of migration from Africa said that 94% of migration from Africa is regular.
So our focus is on the 10%.
Yeah,
and
well,
that
it's
10%,
actually 6%.
6%. Well,
Yes.
that 6% is making big news.
Yes. Yeah, it's making big news for some reasons. I mean, if you take population of Nigeria, for instance, if we're working with 200 million, if 6% of 200 million batches on somebody's border irregularly, it will be a concern for such persons or countries, as the case may be. But we found this situation where a number of our colleagues, brothers and sisters who want to eke out living in other countries, choose this alternative way or are lured into it by syndicates that operate in that area. Now, it is making the news today because in the recent days after the assuming of office of the new American president, or the 47th president of the United States, Donald Trump, and his decision to embark on massive repatriation or deportation or return of those who are in irregular status in their country, many countries are beginning to sit up. Some are getting prepared in terms of what will follow up next. And that excitement or that fear is also what is making it a public news today. As we said, in different platforms of media, you will hear such news, even in popular and then regular news. You see that. Now, why is it an issue? I don't think the issues of return is a new thing. It's just because of the recent happening. And as you likely said, the underlying principle of return is couched in the current migration global framework called the Global Compact for Safe, Orderly and Regular Migration, adopted by the United Nations member states in 2018. The Objective 21 of this this compact indicates and stipulates that all returns must be dignified, and it must also end up with a sustainable reintegration. In other words, such persons who have to leave or removed from the countries of destination must be done in a humane manner. Their dignity must be ensured in all the processes of return, from pre-departure to departure to readmission into their country and up to the reintegration. Then at the stage of...
Father, sorry to butt in here. Does
Yes.
it therefore qualify if,
Yes.
for instance, ICE comes to my place of work, I mean, irrespective of my status, granted, yes, I'm not regular, I'm an irregular migrant, and then therefore they come to my place of work, I'm arrested, I'm taken to a facility, put in a cage, I'm handcuffed, taken in a transport to the airport, and another caged, locked vehicle, and put in the next available flight alongside some other of my countrymen. And then I am unceremoniously, without recourse to retrieving any of my property or reaching out to any family that I might be leaving behind, and then and put in an aircraft and deported back to Nigeria. Does that qualify as humane?
That is absolutely not humane. The way you described it is already an abuse of human rights, and it also builds on very sensitive issue which migration governance pushes at. That is ensuring that migrants are not criminalized on any account. Even if they take irregular routes to go into the migration processes, that does not make them criminals. In 1975, the United Nations General Assembly passed this resolution calling for countries to abandon the criminalization attitude of migrants. And by this, they also advanced that immigration issues should be separated from criminal issues, so that on no account will somebody who finds himself in irregular status will be treated as we said. And as I said, the Objective 21 of the GCM simply states it, that it must be dignified. And anything that is done in chains, anything that is done in that forceful removal, as you pointed out, going to your office or your place of work, arrest you, bundle you, put you in the next detention center, bundle you into the available flight in chains and shackles. Already you can see that it is not a humane thing. It is an abuse of human rights. And this is what both advocates of human rights in migration space continues to push.
Father,
yes.
Not to preempt your press briefing, because I do understand that civil society intends to address some of the incidents that have taken place. Would you very quickly tell our viewer the particular case that caught your attention and why your group, why the civil society is taking an interest in this case, and then make what's the call to action here?
Thank you for saying that, and I hope I'm not spilling the beans or letting the cat off the bag yet. We are actually not responding to a particular case.
Okay, so it's a gamut.
Yes, we are using a recent happening to draw attention to what is a persistent recalling in the course of return projects. What we are saying again, as I said, it is not just this action of the United States that makes return an issue.
Okay.
We have had a series of return projects, and unfortunately, some of them have not adhered to that international standard of dignified return. And why it is concerning is that this is happening from some part of the continents and world or countries that also signed up to the GCM, where this should be a framework of international cooperation. And so we have seen in recent time, following different return issues from Europe, as the case may be, countries that are friends to Nigeria, both in bilateral and multilateral relationship, engaging in return that those who are at the point of reception of this individual found cases that are troublesome. You know, some individuals are removed from the countries, violating the established international principles like medical issue, that no migrant who has a medical condition and is declared unfit to travel should be deported on that condition. And you have to explore everything to stabilize that person and to ensure the person is able to fly or able to be deported. And one of the conditions is that when such is to be the case, there must be an establishment of a continuum of that person's medical attention. In other words, you must identify a medical facility in the home country where it's going to be deported so that such person's medical attention will continue. But we find situation in the recent happenings where people are just bundled, even with medical reports from destination countries, manhandled in different forms and returned back home. Yes. So we would want to use opportunity of our relationship with the Nigerian government in migration governance to say we have to double up our efforts to ensure that our Nigerian citizens are respected, irrespective of their migratory status. And I want to quickly chip in that
Father, we're out of time.
In the Nigerian space of migration management, We have a very robust migration governance policy, which provides for a standard operating procedure for return, readmission, and integration. And this provides for what the GCM has also asked for, the safe and dignified return, as well as sustainable development. So we want to see that the operationalization of this ensures that Nigerians are available.
Father, I mean, you and I will talk, well, in due time, perhaps another time. I will create another opportunity. We'll look at the issue of counseling. I mean, there's a physical side, there's an emotional, psychological, you know, aspect to this discourse in terms of the disposition of deportees back to the country. There's also an economic angle to it. You know, the economic hardship that accompanies deportation. I would also like for us to take on that. All of this as part of, you know, the reintegration process of deportees back to the country. I mean, but for now, the situation is quite fluid, so we're monitoring the trends, as it were, and I will bring you back into the studio, and then we can continue this conversation another time when I create another opportunity. Reverend Father Emeka Chris Obiezu, OSA. OSA. Well, I've forgotten what it stands for.
Order of St. Augustine.
Order of St. Augustine. Father, can I get one? Order of St. Augustine. I need to go to the seminary.
You need to go
and then practice for some.
Yes.
That is overtaking. I'd like to thank you so much, Director, Augustinian Center for Advocacy, Justice and Peace, and National Coordinator, Civil Society Network on Migration and Development. I'd like to thank you so much for coming on Inside. It's good to have you back here. I mean, going forward, we'll be monitoring the trends, not just in the U.S., of course, in Europe and other parts of the world. And we'll bring you from time to time into the studio to talk about this ongoing situation. Thank you so much for coming on the program.
Thank you, Nnamdi. It's a pleasure being here, and let's be our brothers and sisters keeper. Thank you.
Very well. True indeed. Elizabeth Omori is up next. She will be talking about the dangers of self-medication. Are you one of those who indulge in that practice? Watch out. Elizabeth is up next.
Self-medication is a human behavior in which an individual uses a substance or any influence to self-administer treatment for physical or psychological conditions, for example, headaches or fatigue. The substances mostly used in self-medication are over-the-counter drugs and dietary supplements, which are used to treat common health issues at home. These do not require a doctor's prescription to obtain, and in some countries are available in supermarkets and convenience stores. This behavior, medical experts say, is dangerous, and there is a need to strengthen advocacy in this regard to save more lives, reduce the prevalence of cancer, and curb addiction. Today, Ayuba Tanko Ibrahim, President Pharmaceutical Society of Nigeria, will educate us on this segment. Sir, thank you so much for joining us on Insight today.
Thank you for having me too.
Thank you very much. Now let's begin. What seems to be the problem with drug usage in Nigeria? Regulation or negligence?
Under normal circumstances, drugs are manufactured or made to treat illnesses. So in any normal society, when you are ill, you are supposed to see a health professional. If you have a serious illness, you need to go to a hospital and see a doctor who will see you, carry out examination, make his diagnosis, then he will give you treatment. Some may include drugs, some may not include drugs. Then if it includes drugs, you go to the pharmacy to collect your medication, and the pharmacist will dispense your drug, counsel you, advise you, call your attention to things you should not do when you are taking the drugs, and then you go home. But as an individual, there are drugs you can go and buy without seeing a doctor.
Okay.
And those drugs are called over-the-counter drugs. But for your own safety, if you want to buy such drugs, it's better you go to a pharmacy where a registered pharmacist is in charge. The pharmacist will be able to advise you properly on how to take the drug. But unfortunately for us, we have a proliferation of patent medicine stores that are not even registered. And that's where a lot of people go to buy their drugs. So that's why we have problem with drug usage in Nigeria.
Okay. I'm happy you mentioned over-the-counter drugs. This is still an issue because there is no control. From what you said, some drugs are just, oh, I feel headache. I go get an analgesic that suits me. But this is an issue. Shouldn't there be control?
Yeah, there is a drug distribution policy by the federal government of Nigeria to control how drugs from manufacturing to distribution to usage, the processes they are supposed to go through. But unfortunately, it's just on paper. It's not being implemented properly. The drug market or the drug distribution system is choked with non-professionals. Nigerians consider pharmacy practice as a trade and not as a profession. So anybody with some money can decide to go into drug business. And to him, he's just doing business. So he does not mind selling expired drugs, updating the dates of expired drugs. Anyhow he cuts corners to make money. He doesn't care because he's not professionally trained. He's just a trader. But a professional who is trained, a pharmacist, knows the responsibilities that are on him, the oaths he has taken, and the consequences of not carrying out his profession according to the railed down rules and regulations.
It means it's a no-no for those that feel, oh, they want to invest in a particular business. Let's go into pharmacy. It's a no-no for them. Now, I need you to educate Nigerians on the dangers of over-the-counter drugs, drugs that are not prescribed by doctors. Some don't see it as anything because people believe what they tell them. They do not know where these drugs come from, their expiration dates, nothing. But they just consume them because they want to get well. What are the dangers?
There are a lot of dangers with consuming drugs, not only over-the-counter drugs. In my pharmacology class, the first statement our professor taught me or taught us was, every drug is a poison, and every poison is a drug. Every drug is a poison, and every poison is a drug. So a drug as simple as paracetamol can harm your liver, can harm your kidney if you play with it. So there's nothing like an absolutely safe drug.
Okay.
So in order to protect the society from harmful effects of drugs, that was advised earlier on. If the doctor prescribes a drug for you, your best bet is to go to a pharmacy where a registered pharmacist will attend to you and counsel you. And if it is an over-the-counter drug, it will be better for you to seek advice when you go to buy the drug, to seek the advice of a resident pharmacist in that pharmacy who will advise you and direct you as the proper drug to buy and the proper way to use it. Otherwise, if you leave it laissez-faire, anybody, when he feels headache, can go and buy anything he likes and take. A headache is just a symptom of some illnesses. You could have a serious illness underneath, but it manifests in headache and some other symptoms. So when you go and take drug and use, you are just doing what we call palliative treatment. So if the disease is not that serious, maybe malaria or something, you are aware that it is what I did that is causing me this, you can go and buy over-the-counter drugs and take with advice, definitely. But if you don't know the cause of your constant headache or whatever it is that you are feeling, I will advise, go to a hospital, see a doctor, be properly examined, and then he will prescribe drugs for you. Then you go to the pharmacy to go and obtain your drugs. If it's in the hospital, you go to the hospital pharmacist. If you don't want to go to the hospital pharmacy, you can go to a proper pharmacy registered in town to buy your drugs.
To buy your drugs. Now, let's talk about the youths. When we talk about drug abuse, drug misuse, oftentimes the youths are involved. How do we strengthen advocacy on drug use?
Yeah, this is a very, very big problem. In Nigeria, our youth have been devastated with drug use and abuse. And unfortunately, it's not only the youth. I hear that even housewives are involved now. The number one problem is easy access to the drugs. Easy access to the drugs. There's no pharmacist worth his salt that will stock narcotics or drugs of abuse and be selling in this pharmacy. These patent medicine stores you see everywhere, some of them are legal because they have obtained a license to operate, but there is a limit to the number of drugs they can sell or the type of drug they can sell. But what we have in Nigeria is that the moment he receives that license, and there is a list of drugs he can sell, he now extends it to whatever drug he wants.
He sells everything.
And sells everything. So there's a need to sanitize.
Now, it's the Cancer Awareness Week, and advocacy actually has been heightened, and we are told that there seem to be issues with cancer drugs. Some drugs do not really work the way they should in particular persons or race. Could you enlighten us about that?
Yeah, it's multifaceted.
Okay.
Because there are some drugs that do not work properly in certain races,
okay,
but can work better in other races.
Okay.
And there are some drugs that have individual differences. They can work in Mr. A and refuse to work in Mr. B. So I want to believe it's not a general thing, but the race thing is true. It has to do with genetics. And then the individual difference too is true. But let's now go to holistically to the type of drug or how it is manufactured. We are aware that we have problems with counterfeit, fake, and adulterated drugs in Nigeria. Maybe the reason the drugs are not working is because they are not genuine. If we have genuine drugs that are not working, then you can attribute it to what you just said. Maybe race difference or individual differences. But in many cases, the drugs are not genuine. They are either counterfeit or adulterated or sub-dose. You are taking the sub-dose, not the proper dose of the drug you are taking. But on the paper or on the cover, you see, let's say 500 milligrams. But in actual fact, what is inside is 250 milligrams. So you are maybe you are taking the actual drug, but not to the level you are supposed to be taking it. So that's why you have treatment failure. So this thing with cancer, I don't want to believe some people can go to the extent of adulterating or faking cancer drugs, but it's an international business.
Okay.
Any drug that is expensive, they will fake it all over the world.
Okay, yeah, recently I spoke with some cancer survivors and some still living with the disease. They actually mentioned the issue of drug purchase. They said NHIA does not cover particular drugs for them. What is your society doing in this regard, or are you aware of this situation?
Yeah, NHIA was set up with good intention,
okay,
just like NHS in UK and other countries. Okay. Healthcare is a teamwork. It's a holistic thing. When you say healthcare, you are talking about the medical doctor, pharmacists, nurses, lab scientists, physiotherapists, radiographers, and so on. So when you talk about health insurance, the initial law that was set up was for doctors to treat patients in their hospitals and send the prescription to a pharmacist who would dispense the drugs. And unless you include everybody, we have been appealing, they should come back to the table. Let's have a holistic approach. Everybody should participate, and everybody should be compensated according to what he has done.
Okay, there's another common issue amongst some Nigerians. You know, some persons come up with a particular symptom, and then you hear, oh, it's malaria, oh, it's typhoid. Go and take this, go and buy that. We need to change the narrative to save more lives. What advice would you give to Nigerians?
You know, in Nigeria, everybody is a health expert. Whenever you are ill, different people will be giving you different advice. They are not doctors, they are not pharmacists, they are not nurses, but they'll be telling you what to take. When my grandmother was ill, this is what she took, and she got well. When my child was ill, if you have certain diseases and you go to a hospital and they give you drugs and you get well, it doesn't mean that even you yourself, when you have the illness again, you should be able to diagnose yourself and self-medicate. Always seek professional advice. But don't take advice from your friends and relatives that will tell you that, and the last time I was ill, I took this. The last time I had this disease, I took this and I get well. It's a no, please. Mind you, it's not every codeine-based drug that is illegal to sell. Cough syrups are cough syrups. And most of the time, they are over-the-counter drugs. So the manufacturers made their drugs for somebody who is having cough. So if somebody is, if he says take 1 tablespoon, and somebody goes and buys the whole bottle and gulps it down, you cannot blame the person that manufactured the drug, and you cannot blame the pharmacist that sold the drug. But for you to have control as a pharmacist, as a professional, when a youth comes to buy cough syrup and you suspect he may likely abuse it, please don't sell to him. Likely to abuse, don't sell to him. We should use discretion when we are dispensing or selling drugs. If you put professional input in it when we are selling the drugs or dispensing the drugs, we should be able to know who not to sell to and who to sell to.
Interesting. President, Pharmaceutical Society of Nigeria, we want to thank you so much for enlightening us.
Thank you very much, and thank you to NTA for giving me the opportunity.
And that's it on this episode of the program. Do join us same time next week for more on Insights. My name is Nnamdi Odikpo.
And I'm Elizabeth Omori. We'll see you next week. Bye for now.